All right, guys, welcome back to part 2 of the heart failure series. Today we'll start by talking about inotropics. Inotropics have a positive inotropic effect, so they increase or enhance cardiac contractility. They tell the ventricles to contract harder. If the ventricles contract harder, then they increase stroke volume, and increasing stroke volume increases cardiac output. So inotropics make the heart contract harder in order to pump more blood. The reason or the way that these inotropic agents can tell the heart to contract harder is because they all increase intracellular calcium concentrations. So more calcium inside the myocyte allows the myocyte to contract harder with more force. Now, different inotropic agents do this in different ways. There are 3 major kind of classes or different types of agents that we would classify as inotropics, and they increase intracellular calcium in different ways based on their mechanism of action. But ultimately, regardless of how they do that, an increase in calcium inside the cell allows it to contract harder with more force, so that increases the force of contraction, the amount of blood that the heart is able to pump. Now, that sounds wonderful. However, when inotropic agents, for the most part, when inotropic agents are used long-term, they're associated with reduced survival, which is obviously a bad thing. So we don't use inotropic agents chronically. We don't use them long-term. The use of inotropic agents is very limited to short periods of time, so short-term use in the inpatient setting. We'll see for most of the inotropic agents, we'll use them IV when a patient is in the inpatient setting because of an acute heart failure, some sort of a situation that is emergent that we need to take care of right away, and then we stop use of the inotropics when the patient is stabilized and they're going to be discharged. There is an exception here though. Digoxin. Digoxin is a digitalis glycoside. It's the only digitalis glycoside that we use here in the United States, but digoxin is used chronically. Digoxin is used chronically for heart failure. Also, we'll see it's used commonly for atrial fibrillation, so we use it for heart failure and AFib. Otherwise, though, the beta-agonists and phosphodiesterase inhibitors, we just use short-term to stabilize a patient, and then we stop use. So inotropic agents include beta-agonists. Beta-agonists we already mentioned back when we first started Pharmacology 1, but we'll talk about them just a little bit in their use in heart failure during this lecture. So beta-agonists include dopamine, dobutamine, the phosphodiesterase inhibitor that's used for acute situations is milrinone. And that's milrinone, M-I-L-R-I-N-O-N-E. And then again, the digitalis glycoside that we'll use is digoxin. We'll start with beta-agonists. Beta-agonists, again, include dopamine and dobutamine. Beta-agonists bind to beta-adrenergic receptors on the heart, so they bind to beta-1 receptors. And activate those receptors. binding to the beta receptor on the heart, which you see right here, activates adenylyl cyclase. Activating adenylyl cyclase increases the production of cyclic AMP. This increased production of cyclic AMP activates protein kinase. So you see here we have an increase in active protein kinase. That protein kinase phosphorylates calcium channels, and the phosphorylated calcium channel remains open, increasing calcium entry into the cardiac myocyte. So here you see increased calcium being allowed to enter into the myocyte. And you guys know that an increase in intracellular calcium is what gives us that positive inotropic effect, right? That's what gives us the increase in contractility. Increasing contractility increases stroke volume, and we know that an increase in stroke volume is going to increase cardiac output. Beta agonists are also associated with a bit of vasodilation, most likely reflexive vasodilation, but vasodilation decreases afterload, and if afterload is decreased, then we know that that also increases stroke volume. So ultimately, beta agonists are associated with an increase in intracellular calcium, which leads to an increase in cardiac output. So positive inotropic effects. We know that these positive inotropic effects increase cardiac performance in the short term, okay? But used long term, they are associated with a decrease in survival. So we do not use them long term ever. We typically will use them short term to improve cardiac performance in heart failure patients. They are given by IV infusion. The only caveat here, the only kind of time when we might use them a little bit differently, is we can use them intermediate. Dobutamine specifically, dobutamine can be considered for intermediate term use. In the outpatient setting for palliative care. So for palliative care, obviously, we're not worried about survival at this point. With palliative care, you're just worried about making the patient comfortable. You've already given in to the fact that the patient is not going to survive. So in palliative care, dobutamine can be given for intermediate term treatment. Otherwise, the beta agonists are just used to stabilize a patient who is in acute heart failure. And then once a patient's been stabilized, they should be switched to something that is associated with improved survival. Phosphodiesterase inhibitors like milrinone also increase cyclic AMP to lead to an increased intracellular calcium. So they have the same ultimate effect that we saw with beta agonists. They just get there a little bit differently. The beta agonists bind to the beta receptor, and we know that that activates adenylyl cyclase, which produces cyclic AMP. The phosphodiesterase inhibitors, so milrinone is working down here. What milrinone does is it inhibits the breakdown of cyclic AMP. So beta agonists increase the production of cyclic AMP. Phosphodiesterase inhibitors inhibit the breakdown of cyclic AMP. So typically the cyclic AMP that's produced is broken down by phosphodiesterase. Milrinone inhibits that phosphodiesterase, so it inhibits the breakdown, so it's increasing the amount of cyclic AMP that's available in the cell, or prolonging the action of cyclic AMP inside the myocyte. Prolonging the action of cyclic AMP prolongs the amount or increases the amount of active protein kinase. And we just saw before that protein kinase is the enzyme that phosphorylates the calcium channel, and that increases the amount of calcium that's able to enter into the cell. So regardless of all of this busy stuff, right, regardless of how it gets there, both milrinone as well as the beta agonists like dopamine and dobutamine increase the amount of cyclic AMP that's available, which leads to an increase in intracellular calcium. We've mentioned a few times now that an increase in intracellular calcium increases the contractility of the cardiac myocyte, right, which that's our positive inotropic action, which increases the stroke volume, which increases cardiac output. In the short term, that increase in cardiac output is beneficial. It allows us to stabilize a patient that is in acute heart failure. However, long term, it's associated with reduced survival. So milrinone is not something that we rely on to treat chronic heart failure. It's simply used to stabilize a patient who is in acute heart failure. Milrinone is given via IV infusion. Again, it's used for the short-term treatment of acute heart failure in the hospital setting. Notice I have my asterisks here, so there is one caveat, just like we saw with dobutamine. Dobutamine and milrinone can both be considered for intermediate term treatment in the outpatient setting for palliative care. Again, in the setting of palliative care, we're not worried about long-term survival. So if milrinone can be given to increase how comfortable the patient is for increasing their cardiac output, then that's okay. It can be used in that case. Otherwise, only in the hospital to stabilize a patient in acute heart failure. Finally, we'll talk about the digitalis glycosides, which are quite a bit more versatile in their use. This is the only inotropic agent that we do use long-term for chronic heart failure, and we'll see that we actually use it for other cardiac conditions as well. The digitalis glycosides, or they're also called cardiac glycosides, are a group of agents that are all chemically similar to each other, that all come from the digitalis plant, hence the fact that we call them digitalis glycosides. The digitalis plant is commonly called the foxglove plant. So there are lots of warnings about consuming the foxglove plant because it does have these digitalis glycosides or cardiac glycosides present. The only available pharmacologic or pharmaceutic agent that we use in this class is digoxin. The mechanism of action of digoxin is inhibition of sodium-potassium ATPase. Sodium-potassium ATPase is the enzyme that's necessary in order to fuel the sodium-potassium exchange pump or sodium-potassium ATPase pump. Before we look at the way that digoxin works, let's just take a second to look at a normal cardiac myocyte, right? The transporters that are working in a normal myocyte. So if you look down here at this picture, this blue pump is showing you the sodium-potassium exchange pump or sodium-potassium ATPase pump. Remember that this is the pump that's responsible for maintaining sodium and potassium gradients across the plasma membrane. This is an active pump, right? Hence ATPase. It's an active pump that uses ATP to pump ions against their concentration gradient. It exchanges 3 sodium for 2 potassium. So for every molecule of ATP that's used, it sends 3 sodium out and pumps 2 potassium in. It cannot do this without ATP, right? And ATPase is the enzyme that's responsible for breaking that third phosphate bond and releasing the energy. So ATPase allows us to get energy from ATP, and we utilize that energy to pump 3 sodium out and 2 potassium in. This is responsible for making the large concentration gradients that we have. So because of this pump, we end up with a ton of sodium outside and much less sodium inside. So we end up with a large concentration gradient for sodium. Now over here in the sodium-calcium exchanger, we exchange sodium and calcium. The sodium is just going down its concentration gradient. So that's what's fueling this pump. It's not utilizing ATP. The sodium is going down its concentration gradient, which is very big because of the sodium-potassium exchange pump. So sodium's coming down its concentration gradient, and then calcium is going in the opposite direction. Calcium is being pumped out of the cell. So the combination of these 2 pumps is utilized to remove calcium from the myocyte. Now let's look at the way that digoxin works. Digoxin inhibits the sodium-potassium ATPase, so it inhibits the removal of sodium from the cell. Inhibiting this exchanger, again, inhibits bringing in of potassium and kicking out of sodium. So now there's an interruption in the production of the sodium gradient. So now we don't have a large concentration gradient here. And remember, this large concentration gradient for sodium is important to fuel this sodium-calcium exchanger. Now the concentration of intracellular sodium is higher. Now we have more sodium inside, and we don't have that large concentration comparatively outside. Okay, so we are decreasing the driving force for this pump. So slowing down this sodium-calcium exchanger decreases the amount of calcium that we're able to pump out of the cell. Okay, so decreased concentration gradient to fuel the sodium-calcium exchanger means there's an increased intracellular concentration of calcium. And this whole time we've been saying if there's more intracellular calcium, that means there's more force of contraction. So increasing this force of contraction increases cardiac output more towards that of a normal heart. So decreases the problems that are associated with heart failure. Digoxin also happens to increase vagal tone. right? So like base transmission via the vagus nerve. And because of that, it's associated with a decrease in heart rate. Because of this, because it slows conduction velocity through the AV node, digoxin is also useful for AFib. And we'll talk about arrhythmias in the next section. So we will talk about digoxin quite a bit when we talk about AFib. The exact mechanisms and reasons why this happens at a low dose aren't known or aren't understood well, but low dose digoxin inhibits sympathetic activation and vascular tone without decreasing contractility. Because of this, we target a low serum concentration, is the target in heart failure. Whereas in AFib, in the next chapter, we'll see that we target a higher serum concentration. We'll talk about this again momentarily, but it is extremely important to keep in mind that digoxin has a low therapeutic index. This means that there is very little difference in the therapeutic concentration and the toxic concentration. So slight increases in dose or slight adjustments, like drug interactions, for example, that would affect drug concentration or serum concentration can be very dangerous or even fatal. So it is very important to monitor digoxin concentrations and to watch drug interactions, to watch any changes that might occur in the patient that would affect digoxin concentrations very, very closely because it has a low therapeutic index. Digitalis glycoside, so again, digoxin, is used in heart failure with reduced ejection fraction that is still symptomatic on optimal heart failure pharmacotherapy. So it's not used as the primary drug of choice. It's utilized after patients have already been stabilized or are already on optimal heart failure therapy and they are still symptomatic. We'll look at that progression of therapy again at the very end of this lecture. When digoxin is used in heart failure, the serum drug concentration that is targeted is lower than in AFib, for example. So we target 0.5 to 0.8 nanograms per microliter. The kinetics of digoxin are a little strange, and because this is a low therapeutic index drug, it is important to know the kinetics and pay attention to the kinetics because you don't want to do anything that's going to make the serum drug concentration jump, because very close to a therapeutic concentration is the toxic concentration. Digoxin is available in oral and IV formulations, so it is used for chronic outpatient therapy in its oral form. When we look at the dosing of digoxin, especially if you're looking at, giving it IV in the hospital or giving it in an acute situation, the dose is calculated based on weight. Now, it is important to keep in mind that the dose is based on lean body weight. Digoxin accumulates in muscle. It does not accumulate in fat. So patients who are obese, obesity, if it's an increase in adipose tissue, does not affect dosing, right? So that's really important. You do not want to do a weight-based dose that is really, really high because the patient is obese. You're going to be giving them way too much drug. Digoxin has a very long half-life. The half-life of the drug is between 30 and 40 hours. The half-life is between 30 and 40 hours. So it's important to kind of think about what that means when you talk about serum drug monitoring or drug concentration monitoring and dosing considerations and changing the doses. Remember that it takes between 4 and 5 half-lives before you get to steady state concentration, right? Where you're at your normal steady concentration and what's being absorbed is the same as what's being excreted. So it takes about a week before the patient is at the steady state concentration. So think about like dosing changes, for example. If you adjust the dose, it takes approximately 1 week before the full effect is seen. Which means you should not adjust the dose and then the next day say, oh, not good enough, we need to increase the dose more. And then the next day say, oh, we need to increase the dose more. Because then at the end of your 4 to 5 half-lives, you're going to end up with a much greater effect than you anticipated. So it is important to take your time when making dose changes. Also, in acute situations, which we'll talk about when we talk about arrhythmias and when we talk about AFib, but in acute situations like symptomatic AFib, for example, a loading dose can be given. So remember, a loading dose is like a large initial dose that gets you up to your steady state concentration so that you don't have to wait that full week before you're at steady state. Renal dose adjustment is necessary with digoxin. This is important to make sure you know, because again, this drug has a low therapeutic index. So anything that alters concentrations can greatly alter the toxicity of the drug. Digoxin is well tolerated at low serum concentrations. However, it has a very narrow therapeutic index and toxic levels can be easy to reach. Notice I've mentioned this like 5 times. So it's very important to remember that digoxin has a narrow therapeutic index. So caution with dose changes when adding a new medication. When a patient's renal failure is decreasing. Anytime anything is happening, if the patient is on digoxin, make sure you double check that it's not going to affect this, right? So the patient has an infection, you're going to prescribe an antibiotic. You need to make sure that the antibiotic is not going to affect their digoxin, okay? So digoxin, again, it's relatively well tolerated in heart failure because we target low serum concentrations in heart failure. Anorexia, nausea and vomiting, blurred vision, and kind of a yellowish vision, like a yellow hue to vision, are some of the earliest signs of toxicity. Again, toxicity is rare in heart failure, though, because we're targeting such a low concentration. But the patient should be aware that if they start to experience these symptoms, that is problematic and that they need to get a hold of you immediately. When the sodium-potassium ATPase enzyme is markedly inhibited, membrane potential rises. So like the resting membrane potential is not quite as negative. It's less negative, meaning it's closer to the threshold voltage. This makes cells really excitable. So when serum concentrations are high, cells are really excitable, and this can lead to arrhythmias. So arrhythmias are another sign of digitalis or digoxin toxicity. There are some factors that can predispose patients to toxicity or make toxicities more common. Hypokalemia, for example. Hypokalemia is very problematic in a patient who is on digoxin. And the reason for this is that digoxin and potassium both bind to the same site. So digoxin and potassium bind to the sodium-potassium pump. At the same site. They compete for binding. So when you have a normal amount of potassium and a normal amount of digoxin, they both compete for the site, and there's a normal response, right? A predictable response, a desirable response. However, if you don't have enough potassium, if potassium goes way down, now there's no competition with the digoxin anymore. Right, there's no competition, so digoxin binds to many more sodium-potassium pumps. So in hypokalemia, there's increased binding of digoxin to the sodium-potassium pump, which means there's an increased effect. Okay, so that predisposes a patient to toxicity, even at a normal serum drug concentration. Okay, so if you're looking at labs and the patient's exhibiting signs of toxicity, but when you look at their serum drug concentration, their digoxin concentration, it's in the normal range, or maybe it's on the high side of the normal range, I would check the potassium. So if you see that they're hypokalemic, if they've got low potassium, that's a possibility for why they're exhibiting signs of toxicity. Okay, very important to keep in mind. And I monitor very closely, especially if they're on other agents that can cause hypokalemia, right? Like we just talked about some diuretics, for example, that can cause hypokalemia. Then that's very close monitoring of potassium is important. Digoxin is a substrate of P-glycoprotein. So think back to what P-glycoprotein is. Remember that P-glycoprotein actually pumps the drug back out. So when we're absorbing it from the GI tract, the P-glycoprotein is an efflux pump. It pumps it back out so that we get rid of it. So when you have your patient stabilized on a specific digoxin dose, you're assuming that a normal amount of it is getting pumped by P-glycoprotein, and then a normal amount is getting absorbed, and you're stabilized. If you start the drug on another agent that either inhibits P-glycoprotein or is a substrate that's going to compete for the P-glycoprotein, then that means less digoxin is going to get pumped back out into the GI tract. Right, so if it's given with a substrate or inhibitor of P-glycoprotein, you're going to increase the absorption of the digoxin. So have increased effects of the digoxin. In this case, if you're giving it with another inhibitor or a substrate of P-glycoprotein, what you would need to do is decrease the dose of your digoxin. Examples of this, clarithromycin is a big one here. Sorry, that's really messy. Clarithromycin, verapamil, amiodarone, which amiodarone is an antiarrhythmic that we'll talk about a lot in the next chapter. Also, we mentioned that digoxin slows AV conduction, which was the reason why we used it with AFib. But because digoxin slows AV conduction, you need to be cautious with other drugs that also slow AV conduction. So caution with drugs like beta blockers, verapamil, and diltiazem. Now, right now we're talking about heart failure, right? And we know that verapamil and diltiazem are problematic in heart failure. So that's not a big one here. But beta blockers are used in heart failure, right? So when your patient is already stabilized on heart failure treatment, they're probably on a beta blocker. So just when you're adding on to the digoxin, it's important to watch the heart rate to make sure that you're not slowing that AV conduction too much. We'll change gears a little bit from the inotropic agents and talk about the natriuretic peptides. Remember that natriuretic peptides are naturally occurring in our body anyhow. When there's an increase in the volume of blood being returned to the heart, and an increase in preload, an increased volume that's filling up the ventricles at rest, then natriuretic peptides are released. And the overall point here is to decrease blood volume, to decrease the amount of blood filling the heart at rest so that it's not being stretched too much, so that there's not too much preload. Natriuretic is an agent that we use pharmaceutically that acts just like our natural natriuretic peptides. Natriuretic is used in acute decompensated congestive heart failure when IV diuretics are minimally effective. Again, notice that this is acute decompensated. This is not a chronically used medication. This is just used to relieve heart failure symptoms. For example, dyspnea. Dyspnea, shortness of breath, is the most common symptom here that we're kind of gauging by. But dyspnea, edema as well. Are signs of acute decompensated heart failure. Now, traditionally or typically what you're going to use here are IV diuretics, right? So the first line is an IV diuretic, a loop diuretic specifically, to get rid of excess fluid. However, when you've already given your IV diuretic and that IV diuretic is minimally effective, then you can give the natriuretic. Natriuretic stimulates natriuresis and diuresis. So natriuresis, remember, is just getting rid of sodium in the urine, and diuresis is large volumes of fluid in the urine. Natriuretic can be given via continuous infusion, but more commonly, it's given as an IV bolus injection. It has a short half-life of 20 minutes, so you'll see the effect very rapidly. You'll see it right away, and then you can judge effectiveness. The most common adverse drug effects just have to do with the decreased blood volume. You're shedding large amounts of fluid rapidly, and it takes time for the rest of the cardiovascular system to kind of adjust to that. So it is possible for the patient to experience hypotension and dizziness that's associated with that hypotension. We saw this slide before at the end of the part 1 lecture in heart failure, but we'll take a second to look at it again now that we've studied the last few drugs. When we look here, notice that this is the order of therapy that we're using for chronic heart failure with reduced ejection fraction. We're not looking at acute heart failure. Acute heart failure is what we just saw with the inotropic agents. When you look here, we're just moving our way from the bottom up towards the top. Initially, when a patient is at high risk but they have no symptoms, we do risk factor reduction and patient education. moving our way up, make sure that we're treating any of the other cardiac conditions that are present, or any really related issues that are present, because you see diabetes here as well. So treat hypertension, diabetes, dyslipidemia, etc. ACE inhibitors or ARBs in some patients. Really, if the patient has hypertension, diabetes, they should be on an ACE or an ARB anyhow. So an ACE or an ARB in all patients that can tolerate, I would say at this point. Once there is actual structural heart disease present, then you'll see that we have, so that's, I'm looking at this one right here. Then we're moving up to stage B, and we've got patients on ACE inhibitors or ARBs, and then beta blocker in select patients. This clinically now is typically going to be a low dose of an ACE or an ARB plus a low dose of a beta blocker. And again, that's what this says up here. Historically, beta blockers were added after there was the patient was stabilized on an ACE or an ARB. However, now most patients who are newly diagnosed with heart failure with reduced ejection fraction are going to be initiated on both low dose ACE inhibitor and then beta blocker after the initial stabilization. So again, typically here we do a low dose ACE or ARB and low dose beta blocker. Just to make sure that the patient can tolerate it, as always, we're starting with really low doses and slowly titrating to optimal levels, because you don't want to bottom the patient out right away, and you don't want the patient to be absolutely miserable and then compliance decreases. So starting patients who have structural heart changes on a low dose ACE inhibitor and low dose beta blocker is effective. If the patient is stabilized on both a ACE inhibitor and a beta blocker, but they have symptoms occur, right? They're showing worsening of the heart failure. At that point, you move up in the next step and you can add an aldosterone antagonist, right? Like a eplerenone or a spironolactone. And then also the fixed dose combination hydralazine and isosorbide dinitrate in some patients. Once you have the patient stabilized on that, if they worsen, right, become symptomatic and you see signs of worsening heart failure, then you move up. And remember that the next step is to replace the ACE inhibitor or ARB with your combination ARNI. That is, we've got it up here, sacubitril and valsartan. Now, remember that they need to be off their ACE inhibitor. If you had them on an ARB before, you can switch them straight over. But if you had them on an ACE inhibitor, remember that they need to be off the ACE inhibitor before, I think it was for 3 days, before you switch them to the sacubitril valsartan. Double check me on that 3 days, don't quote that. If you have a patient that is stabilized on this therapy and then they have symptoms of worsening heart failure, at that point, this is when you can use, of course, a diuretic in the short term to get rid of fluids, but then you can add digoxin to therapy. And note, I'm saying add all this time. I'm not saying like take away the other drugs and replace them. We're always adding on additional drugs. So you can add digoxin or ivabradine to their current therapy. And again, the diuretic is just symptom management to get rid of the fluid, and that's it. It's the digoxin and the beta blocker and the ACE inhibitor that are actually having a morbidity and mortality benefit. I'm just going to take 1 second to mention heart failure with preserved ejection fraction. The whole rest of the lecture, all of the guidelines and recommendations have all been based on heart failure with reduced ejection fraction. At the very beginning of the first lecture, somebody asked in class, and I kind of mentioned that heart failure with preserved ejection fraction, we really just are managing comorbid conditions. We're not using, digoxin or inotropes, or we don't have a series of recommendations that are always something that you'll follow with heart failure with preserved ejection fraction. Clinical trials have not yet identified effective treatments. So really any of the recommendations that we have or the things that we do are just based on expert opinion. When we talk about heart failure with preserved ejection fraction, when the heart can actually contract well, it's not the contractility that's the problem. It's the filling that's the problem. But the pathophysiology is really complex and it's varied, and there's so many different things that could come into play that there's not one proven treatment that can be recommended for all patients. So we focus on controlling everything else that we do understand. So the focus is on hypertension control, right? So there we're probably talking about an ACE inhibitor or an ARB. Reducing fluid overload. So we have loop diuretics that we'll utilize when there's fluid overload. We have dietary restrictions that can try and help with fluid overload. AFib is present in the majority of patients with heart failure and preserved ejection fraction. So AFib management in that case obviously is necessary. So, and it's not proven whether rate control or rhythm control works best in patients with AFib and heart failure with preserved ejection fraction. But we'll talk about that when we do AFib in the next chapter. So overall, again, there's not one set of recommendations that we can utilize, but we're just essentially managing everything else that's going on, all of the other cardiac conditions, dyslipidemia, all the other stuff that's a problem. And then in doing that, hopefully we're doing the best that we can for the heart failure with preserved ejection fraction as well. I know that's not great. We have a lot more that we can do for heart failure with reduced ejection fraction. All right, guys, that is it. Please just shoot me an email or comment below if you guys have any questions at all, and I will see you next week.